I'm so happy to have Dr. Stephen Chen with us today. I'm putting this in air quotes, met him at a webinar during COVID where, during COVID, we were doing lots of webinars at home. And I thought, food is medicine. This is interesting. Who is this guy? Wow. And then he's going to be creeped out by this. Then I Googled him and he was on lots of webinars and had done lots of things. And so I've been kind of an intellectual secret stalker for the last year. And then when I reached out to him and said, we are trying to do this in Kansas, very different from California, but some of the issues are the same. Would you be willing to speak to our group? And he so graciously agreed. I hope that you will find the story of Alameda All In and Recipe4Health as inspiring as I had. His bio is in your packet, and you can also find a lot more about it on their website. This session will be recorded so that you can refer back to it later or send to others. So without further ado, thank you so much for joining us, Dr. Chen. I will turn the stage over to you.
Well, thank you so much. This is a fabulous opportunity. My name is Stephen Chen, and I'm the Chief Medical Officer for Alameda County's Recipe4Health initiative. I am going to share my screen, and my understanding is I have about up to an hour. So I will be sharing the story of Recipe4Health, wondering how does this apply to Kansas, and wanting to be in a Q&A with you all about that. If we have time and it makes sense, I can also give you visibility with a short video into some of our work. So with that, I'm going to test this out and make sure this is all set up. And we're going to start. I'm going to try it on this way. Can you see my screen? I'll lean a little.
Yep, we can. Looks great.
Okay, now in seeing the screen, do you see the main presentation, or do you see everything else, like with notes and next slide and all of that?
We just see the screen. So
Wonderful.
We don't see your notes and we don't see anything in it. So yes.
All right. Well, fantastic. So this is such an honor to be with you all. And I thank you so much for the opportunity. I was thinking about this opportunity in Kansas, and I thought about the symbolism of the sunflower. I understand you are the sunflower state. And some of the intersections and connections to the symbol of the sunflower that have happened historically and worldwide. You being the sunflower state and what the sunflower can represent around hope and transformation and change, I wanted to name and locate myself in that and my heritage as a Taiwanese American. In 2014, this Taiwan Sunflower Movement occurred. This was a youth-led movement that ushered in a new era of Taiwanese identity, that flipped the old order on its head, where in the past Taiwanese identity was pushed down. In the new order, Taiwanese identity had prominence. So a new order and a representation of hope and ushering in a new era. We also know in recent current events, Ukraine and the story of Ukraine, where the sunflower is their national emblem. And in this day, it's a story of resistance and a story of hope and a story of solidarity, with the sunflower being an opportunity for others worldwide to show their solidarity with them by sharing either the Ukrainian flag or the sunflower. And then certainly the great state of Kansas, right? You guys are Sunflower State and the Sunflower Foundation in bringing food as medicine in this moment together. Food as medicine and the sunflower as a symbol of ushering a new era of medicine, connecting some of the old with the new, but doing it in a new way, and solidarity with other sectors like food systems and ag. And I'll share with you what we're doing in Alameda County. So again, thank you all. I looked at the roster of who is in this room, a powerhouse of amazing change agents across the state, FQHCs representing rural and other parts of the state, CEOs, providers, folks from the tribal community. It's pretty amazing what you are all coming together with. And so really excited to see where Kansas takes this work in terms of food as medicine. My agenda, if you will, is really simple. I'm going to share with you why Recipe4Health. That's our model of food as medicine. What is Recipe4Health? Preliminary outcomes, because I understand that you have some data people in the house and some evaluation teams, and it's always good to be able to, when you're embarking on a new initiative, to be able to tell the story from a data perspective as well as a qualitative perspective, and a lived experience perspective. And then systems change. I'm actually okay here if you all want to interrupt me or make this interactive. I know it's me talking at you. If there's a way that you want to raise your hand or signal to me, I can see you in this setup. I can see the whole room. But if folks want to speak into the mic, or if there are folks joining in and want to type in, I don't know if I have access to the chat, but maybe someone can alert me. So I welcome you. Otherwise, you're just going to hear me talking at you. But hopefully we'll get through it and we'll have some Q&A. So why Recipe4Health? It's often important to start with the origin of any initiative. And I'm going to add the legacy. And so I'm going to share a little about the origin and legacy story briefly, because it may be useful to you all in this moment to think, what is your origin story as this develops and as you fast forward 5 years, 10 years from now? This origin story started with food as medicine at Hayward Wellness in Alameda Health System. The names don't matter to you. Just know that I was the medical director at this FQHC, Federally Qualified Health Center, just like many of you are in this room. There are some of your clinical champions here at our county health system. And we started to embark on this food as medicine journey then. At the same time, my colleagues at Children's Hospital in Oakland, in the same Alameda County, under Supervisor Chen, were beginning to do some work. Supervisor Wilma Chan was, I should say, one of our 5 supervisors in the whole county. She is essentially helping to run the county. She tragically died last November, hit by a car while walking. And so we have all as a county embraced not only her work and its origin story, but its legacy. When she recruited me over to join Alameda County at the system level, it was to spread and scale Recipe4Health in Alameda County across all the FQHCs and health systems, food systems, whatnot, to take it to other counties in California, and if it took on elsewhere, to other states and nationally. So here's an opportunity to share what we know and potentially future partnerships with you all. Part of the origin and legacy story here is when you are creating a new initiative, you need multiple levels of people aligning. With these, we had myself as a physician champion with the health system. We had another physician champion. But we could have just toiled away in our physician kind of world, and it may not have gone anywhere. Here we had an example of a visionary leader, and she was the former assembly leader at the whole state. She had 30 years of history, very powerful person, but a powerful person calling forth a large vision that we could all organize under, and then resourcing it, bringing in resources of funding, positional power, and whatnot. So this legacy carries forth, and in a sense, I think she'd be very proud to know that you all have a chance to hear about our work today. So fast forward now, just to kind of what the ethos of what we're trying to do with Recipe4Health. This is high level stuff. We are bridging silos. And then as I've been in conversations with the federal government, I'm seeing that Alameda County is not unique in that we have silos. The federal government is structured in silos. I'm not sure how Kansas is set up, but we in health are often stuck in our health silo. The food people are stuck in their silo. So our work in Recipe4Health is to intentionally bring health and food systems together. We also look to where the food comes from. And so that's the soil and land piece, the ag piece, right? We don't often have farmers talking to docs or to cooks, chefs. We also bring an economic analysis to this that you'll hear more about, and then an equity lens. And so all of this is happening intentionally as we do our design, implementation, and optimization of Recipe4Health. I'm going to leave you with a quote that I love and I think is in your packet. Wendell Berry is a poet, is an environmentalist, a farmer, a thought leader. And he said, people are fed by the food industry, which pays no attention to health, and are treated by the health industry, which pays no attention to food. That's certainly been my experience as a physician growing up in the physician world. We just didn't know much about food. We didn't know where it came from. I like to add my little corollary. And both the food and health industry pay no attention to the soil and land. In my conversations at the state, at the county, we're just trying to make this connection between food and health. But I continue to ask, well, where does the food come from? And what is the quality of the food? I want to also recognize that we need to understand on whose land we are living on, right? And the history around that with our Native Americans and our indigenous communities in this country and the history around that. I want to leave you with this website. You can put in your address today where you are all convening and see whose land is this? Which tribe was here or is still here? I know in our community in Alameda County, much of it is Ohlone land, and so we pay respect. But it's more than just paying respect. How do we then allocate resources and support beyond signaling that we understand this? Going to keep on going. So for this big picture, right? Now we're going to get into where we are as healthcare practitioners. So this may look familiar to the practitioners in the room. This is myself in clinic with my medical assistant. When I'm in clinic, just mopping the floor, right? The mopping the floor of diabetes, mopping the floor of depression, all of this, the medical conditions that take 10 to 15 years in the making that I'm trying to clean up in a 15-minute visit. I'm so busy, and you are so busy as a practitioner that you don't see the overflowing faucet sending us more and more patients. We are stuck downstream in healthcare. I often use this other way of explaining it in terms of my day-to-day work, our day-to-day work with the clinicians in the room, managing the diabetes, obesity, all of this together with language discordance or not, recognizing in the back of our head that there's something else that's causing conditions or leading to conditions that lead to my patients developing diabetes. These are the midstream issues, the social determinants of health, food insecurity, social isolation as a social determinant of health, inadequate housing, poverty, public safety, and I'll tell you more about the piece around public safety. And then moving further upstream, the structural determinants of health, policies and systems, food policies, housing systems, economics, racism as a structure. This is what we're contending with when we are downstream, and yet we don't always see all of this or have ways to address this. So the why for Recipe4Health, we are downstream, so how do we start moving upstream? Well, let's start downstream, and let's start downstream in our exam rooms and figure out how can I work in my exam room upstream. So this next slide shares this really important fact. An unhealthy diet now is the leading cause of mortality from a risk factor analysis perspective. If you look at 26 years of data and you line up all the risk factors against each other, dietary risks are leading to the death of our American public at a higher rate than tobacco use, which we all know is a terrible risk factor. And it's at the tune of 500,000 people dying per year attributed to dietary risks or an unhealthy diet. What's the connection then to chronic disease? In the US, this is from the CDC, 6 in 10 adults in the US have chronic disease, and 4 in 10 of them have 2 or more. What's the cost implication? Our annual healthcare costs are $3.8 trillion. Dwarfs the USDA, dwarfs a lot of the other costs in our society. And 90% of that, 3.4 trillion, is chronic disease. That is the bread and butter of what you all do as FQHCs, is trying to change that curve of chronic disease and get people off of that curve or slowed down or stabilized. Now we throw in food insecurity. So we have unhealthy diets, we have chronic disease. What is the implication of an upstream issue like food insecurity? I want to share a study that shows for those who are on the blue line that are food insecure versus those on the red line that are food secure, if you track them out over days, over time, and you look at the probability of them developing diabetes, we are seeing a 200% increase, or a double risk of developing diabetes just by being food insecure alone. Many people say food insecure, that's just about hunger. Let's just give that over to the social services team to manage. We're too busy downstream just dealing with the diabetes. By not addressing food insecurity and having ways to address it upstream, we compound our work downstream. So this is a really important thing for health systems to tackle, but the question is how. We've struggled with addressing social drivers of health, social determinants of health. I also want to add the equity lens. Not sure about the demographics of Kansas, but in the nation, when we look at food insecurity pre-COVID, we see disparities across the board. White households at 8%, that's high already. Latinx households at 16, double. Black households, 21%. Native American, Asian Americans kind of mixed in there, often not visible. But when you look at the overall, prior to the pandemic, 11% of our population was food insecure. You throw in the pandemic, look what happens. And this is a moment in time during the pandemic before all of our federal systems came in with food supports. But that's dramatic. The bottom line was we got a doubling in food insecurity during the pandemic. Now I'm going to throw in this last variable, which is social isolation, also relevant because of the pandemic, relevant to our model because we address this too. Social isolation as a social determinant of health impacts mortality. This is big. If you are socially isolated, your risk of dying is higher than if you drink 6 alcoholic drinks a day, or die higher than if you're treating someone for their blood pressure with blood pressure medicines, higher than someone who's physically inactive, higher than someone who's obese. It's about equivalent to 14 cigarettes a day. So we have food insecurity, we have social isolation, we have all this chronic disease, we have COVID. Oh my, it's depressing. It's like too much. No wonder we in medicine think, oh, just whatever the patient comes to me, I'll just manage them. I can't think of anything else. Let the policy people, let the social services take over. I think we've been asleep at the wheel, or we've been sleeping, if you will, and we need to be awoken because there are simple things we can do. And so the why is the danger, the badness that we're dealing with. The what is what I want to share now in terms of a possibility out, a possible way out. And this is what we're doing in Alameda County, Recipe4Health. You may wonder, what is this, Dr. Chen? What is Recipe4Health? I like to just use this following simple statement. Recipe4Health is an integrative model of healthcare that uses food as medicine to address 3 endpoints, all at the same time. In the exam room, at the clinic level, at the policy level, all at the same time. We look at food insecurity straight on and say we can address this. We actually know that food insecurity is bundled with other social determinants like social isolation, like transportation, and we address that. But we are straight on about dealing with food insecurity because that's actually clinically relevant to us. Chronic conditions, we can address that because that's our bread and butter. And yet we struggle with that in primary care or at the FQHC level. And then we like to put front and center health and racial equity. How do we have that lens to address equity? This recipe leads us to this moment that we're having in California, which is about policy and systems change, where you imagine the day that health plans cover Recipe4Health. I'm going to tell you more at the end of this talk about what we're doing in California. But in about a week, September 1st, we're launching an initiative at the state level that allows health plans, our Medicaid health plans, to cover interventions like Recipe4Health, just like they would cover just like they cover blood pressure medicines, and actually cheaper to do this than a blood pressure medicine or a cardiac catheterization, right? So this is happening. It's not only happening in California, but it's happening in North Carolina, It's happening in Massachusetts. It's happening in Oregon and Washington. So it'll be interesting to see, where does Kansas go with this? And if this is that first beginning of that sunflower, the sunflower flower for you all. This is the today's convening, or the work that you've been done to prepare the land for this moment. All right, now we're getting into kind of the details of the model. And I want to share that, like with any recipe, there's ingredients. And our recipe for health has 3 ingredients. And we structured it to be simply 3 ingredients because we believe that this model is scalable. You may not have the specific particularities that we have, but in terms of the basic ingredients, you can put this together in Kansas. Our 3 ingredients are, number 1, a food pharmacy. I'll share more about that. First ingredient, a food pharmacy. The second ingredient is health coaching via a behavioral pharmacy. See the play on word on pharmacy. Our third ingredient, and it's an important ingredient that has to be named, which is training, food as medicine training. And we have 2 components to that training, and I'll go into more detail. The nutrition education for providers, and then the workflow integration. We work with health plans and the clinics across our county to implement this model. We train the front end clinicians on how to write prescriptions to Recipe4Health. We are going to be talking to the health plan members in terms of their care management teams, population health teams. Potentially they can do the same thing, offer this to their members. And then that's what we're going to see is the patient and community health improving. So simply 3 ingredients. Let me pause because I've been talking at you about 16 minutes. Is there an opportunity where people want to ask a few questions or send me a chat? Let me just do a 10 to 15 second weather check with you all.
Just raise your hand if you have a question. We'll bring you the mic or put it in the chat box. Anyone? I will say, Dr. Chen, when you said we're doing this in California to the state Medicaid, my little table sitting here, we're all like, Kansas is next. So
we'll support you. I'm here to support you. If there's ways that I can be of help, this is a movement that's happening across the nation, and it's really the how-to. And so excited to hear that. If Kansas is next, let's make it happen. All right. I'm going to invite you. You don't have to wait for me to invite you. So I can't quite see everyone. So I'm going to rely on you, Elizabeth, to kind of tell me when someone wants to ask. But I'm going to get into that first ingredient. And ours is I can see folks, but it's maybe not as clear, like if someone's going to try to say something. So food pharmacy, that's our first ingredient. Ours is run through Dig Deep Farms. Dig Deep Farms is a farm. It's an urban farm in Alameda County. And it has a connection to the sheriff's office, if you can imagine that. One of our county institutions, not well liked, our sheriff, for lots of different reasons. And, in terms of the institution, right? And yet we have folks in the sheriff's office that are looking to reimagine public safety. And 10 years ago, or 12 years ago, in 2010, they said, you know what, we are going to get into the business not only of enforcement, which is downstream, like us in healthcare dealing with diabetes downstream. We want to work upstream and address what they call the criminogenic factors to crime. Factors that are very similar to our social determinants of health factors, poverty, joblessness. So they created a farm back in 2010. In this farm, they hire pharmacists. Pharmacists are folks that were formerly incarcerated or on probation. We also work with probation, and they get job training, and they learn about packaging the foods. They can also learn to grow the food in the way that we grow the food, and they can be drivers. So it's a job pathway for folks that have not had a pathway towards jobs when they're coming out of prison or jail or in probation. We grow the food regeneratively. And I'll tell you more about that in a subsequent slide, but no pesticides, nutrient dense. So folks who get jobs get a certification as to they know how to grow this food using regenerative organic practices. And they can stay on as a future job as well. These are living wage jobs. $23 an hour, $20 to $23 an hour, which in the Bay Area is not as much as it might be in other states. We have a refrigerated van fleet that is dropping the food off at our patient's home. So when I write a prescription to my patient with diabetes, and it goes to the electronic health record, our farm receives that. I should say the health plan receives it, and then they authorize it, and then we get it to the farm. And then the farm drives the bundle of food, it's a bag of food, to our patients' homes weekly for 12 weeks, up to 16 weeks sometimes. And it's not this bulk, all these apples, it's actually in bags, but they're refrigerated. And this is a job opportunity as well. We also recognize that in doing this, we have doorstep delivery, 99% delivery. This is better than Grubhub. This is better than Amazon. This is better than whatever your DoorDash. And there's no labor issues. People are paid really well. And it's a great win-win. So this is our food pharmacy. Now, I asked the question earlier, I posed the model of bridge building or silo busting or being intentional about bringing silos together. So it's one thing to have a health center now connected to a farm. That's amazing. That's always hard work, and we're going to get health plans to cover it. We already have that happening. It's another then to ask the question, where does the food come from? Because sometimes our approaches have been just get any food. I've been a volunteer at the food bank, and our food bank is fantastic. Sometimes the food that we get is food that actually leads to disease downstream. So how do we then source the food? So our question in our model is sourcing matters. And we ask the question, where does the food come from? We have urban farms. These two plots of land were on former parking space, concrete. They use permaculture, regenerative practice to convert that abandoned lot into usable farmland. Our county is invested in creating food hubs where we have this food hub where the food that's grown comes and gets processed, cleaned, put in the bags. And there's a commercial kitchen there that is open to food entrepreneurs that don't have the capital to create their own food, and they can sell their food. So it's a job pathway as well, and an economic engine pathway. Our model is committed to a regenerative organic model for where the food comes from, pesticide-free, recognizing that organic in itself allows for a certain amount of pesticides. We use 0 pesticides. It's seasonal, it's fresh, it's local. There's a dedication and a commitment to improving soil health. That's part of what it means to be regenerative, which leads to higher nutrient density food. Soil health equals planetary health, ultimately equals human health. This was initially about an acre of land. Last week, I was at a ribbon cutting ceremony where we partnered with the East Bay Parks Regional, it's Ardenwood Farms, another farm, and got 90 acres of land to produce the food for our clinics and our health systems, 90 acres. And then there's another plot of land, another 10 acres coming from the Masonic. So for us in California, where we're an urban, suburban landscape, 100 acres is a lot. For you in Kansas, that might not be much. You might have vast farmlands that are much more than we have. But we're connecting farms to clinics, and we're taking a regenerative approach. I do want to share just about this regenerative approach, and you may be farm hands in the audience, especially if those who are in maybe the rural communities. I'm simplifying this, but we have ways of producing the food that are maybe more damaging to people on the planet long-term, although short-term it may be needed, and then those that are more beneficial. So on the spectrum, you have conventional industrial, you have conventional small and local, which is great, farmers markets, you have pesticide-free, herbicide-free, you have the kind of conventional organic, and also just a lot of the diversity within organic. And then you have this more regenerative agroecological model. So we're squarely here. You don't necessarily have to be here, but we want to submit that the more we can move along the spectrum, that's not only good for human health, it'll be good for the planet's health. We have wildfire issues in California. I don't know if you are having drought, we're having drought issues as well. So there's a lot of interesting work on, if you take care of the soil, you take care of the earth, because it brings in carbon dioxide from all the emissions into the soil. So carbon capture. Interesting studies around how we can reverse some of the climate issues by investing more in regenerative ag. So that's ingredient one, our food pharmacy. Any quick questions?
Yeah, Dr. Chen, there was a quick question. Can you hear us?
I can hear you.
Great. So there was a question on growing seasons in particular. So certainly California has a much longer growing season than Kansas would. Any suggestions for what that might look like in our state or how you manage that in California?
Yes, absolutely. And this is where you're located makes a difference, right? How are we going to do Recipe4Health in Alaska? It's going to look very different. How does it look like in Kansas? So we are lucky in California to have a year-round growing season. It's just different types of food that are grown. I do think, though, that it raises the question of what are the boundaries of local and how do we do a regional approach? Would Kansas during off seasons be able to partner with another state nearby? And this is where I'm a Californian. I don't know the details of the climate there, where they can get food that's still not necessarily local, or hyper local, but local enough or regional, as opposed to needing to go down to Ecuador to get certain things. But that's an important question to figure out. And we do have I recognize there's a privilege that we have of having growing seasons that are year round. I would love to hear your ideas about that, though, when we go into Q&A, or even now if you have ideas. Okay, I'm going to keep on going. I'm going to move into the behavioral pharmacy or health coaching. And this is to the clinicians in the room. How do you amplify and sustain behavior change in your patients? My experience has often been, and I've been practicing for so many years, 20 plus years, I tell my patients, I make these behavioral prescriptions. Oh, your blood pressure would be better if you exercise more, or eat better. Oh, your depression would be better if you'd reduce your stress. You're totally isolated. Let's get you some social support. And I say, great, in my 10 to 15 minutes, I'll see you in 3 to 4 months. If they come back, my patient will maybe have gotten worse or nothing happened. Didn't create a sustainable plan with them. They didn't necessarily have access to resources. And they're just the limited supportive behavior change. Like, how do we actually make it happen? So this is where we bring in the ingredient number 2, which is our health coaching model. And it's individual and group health coaching. We call that a behavioral pharmacy. We partner with a community-based health coaching team called Open Source Wellness. And I want to offer this to you all because they've told me to offer it. They are ready to scale. They're actually doing work in Colorado and other states. They're ready to scale and bring their coaching work to other community health centers and other even housing places outside of Alameda County, outside the state. So if you are interested in exploring this, or even as we think about what does Recipe4Health look like, happy to connect you all. But what is open source wellness and what does this look like with the clinics? It is a hybrid partnership between open source wellness providing coaches and the clinic providing a provider and a medical assistant, so that each visit that happens weekly with 12 to 24 patients in these groups and their different diagnoses, this is just one part of our model, they would attend weekly visits with the provider. Provider makes it a billable visit. It's great for the FQHCs in terms of just needing to get revenue to cover these services, or to cover the provider time in here. It's transdiagnostic. That's what's really neat. Rather than just a diabetes only group or a depression only group, most of these conditions we address with food as medicine are transdiagnostic. So you can have a diabetic sitting next to a patient with depression, sitting next to a person with high blood pressure. They can all be in the group together. It makes it really easy for the clinicians. What happens in the group, it's not what's happening now. It's not just someone lecturing at you all or telling you all, and you guys are sitting there. It's actually health coaching happening that's interactive. We have a movement coach in the group, and they're literally doing movement together. It's super fun. I've been in the groups. We're doing it virtually as well. There is a nourish piece where there's coaching on the food that's provided from Dig Deep Farms. How do you prepare this local food that I'm not used to and not in my culture? Well, how do I make it interesting? Let's do a food demo, et cetera, et cetera. There is a connection piece where the 12 to 24 patients break out into small groups, and they're in each small group, there's a health coach from Open Source Wellness leading them through. There is the being piece. So just a mindfulness, guided imagery, a piece where the body, mind can be re-regulated and manage stress. And then there's a provider piece where the provider sees the patient. This is our health coaching piece. It's necessary because it's one thing to prescribe food, it's another to use it, and it's even another proposition to integrate life habits into your life for the long haul. By giving a dosage of around 12 to 16 weeks, we're seeing behavior change in those moments of time and potentially afterward. We're studying that. That's our second ingredient. This one is eminently scalable because our open source wellness team is ready to go. When it comes to the third ingredient, this is the one that most people overlook, which is the training. And I know as a doc, and I know as an administrator, sometimes you just throw great people into situations and you hope that they can figure it out, right? That's what we do to docs. You know, go figure this out. You've been trained, you know, you'll figure it out. We do the same to nurses, nurse practitioners, physician assistants. We put a premium on training, and a lot of our training is to expand the mindset. And a lot of it is on, there's a whole section on clinical nutrition training. So let me ask the question to the audience here. In how many hours of training does a doctor get on how to use food as medicine in their 7 years of training, 4 years of med school and 3 years of residency? What's your guess?
We're hearing 0 on this end.
All right, we got 0. Anything beyond 0?
2?
2, yeah. Well, you guys are a lot closer than most people. It's 4 to 7 hours. 4 to 7 hours, and those hours are basically biochemistry and pharmacology, right? It's not how do I use this in the clinic or with my patient. So I and the chef MD and nutritionist, we put together a curriculum to train attending physicians, nurse practitioners, a bunch of people, nurses, nutritionists on application and actually how to use food as medicine in a 15-minute visit to treat, prevent, and I like to say reverse chronic conditions. And I know many of you will say that's just not possible. I've been practicing medicine for 20 years. Once I put someone on a diabetic med, they're on it forever. It's actually possible to take people off. It may not be at scale, but we are seeing that. And that's what we're trying to figure out. How do we get this at scale? So we provide this training so that people know how to write the prescription. We train the medical assistants and other care team members at the clinics how to screen for food insecurity as part of their regular flow of work. We optimize CalFresh. In California, it's called CalFresh. In your state, probably SNAP, but food stamps is the old way of talking about it. We want to connect our front-end services eligibility teams with our electronic health record referrals by the clinicians to make that happen. Because if they can get SNAP, at least in California, they get $200, $300 a month supplemental income to pay for fresh fruits and vegetables and other foods. And the final piece that's non-interesting to most people, but super important for implementation, is we work with the health centers on how do you integrate this into the electronic health record to make this one click for the clinicians? How do you make this into the workflow so it's an easy flow? It's team-based care, and we also brought in our notion of who a prescriber is. So we train up the medical assistants. We train up prescribers that we call prescribers with MAs. These are the doctors and nurse practitioners that are family docs, pediatricians, the women's health providers that have an MA paired to them. We train up that team. We also train up what we call our prescribers without MAs, because we're broadening the definition of prescriber. You don't have to be just an MD or a DO or nurse practitioner to prescribe this food as medicine. You can be a psychiatrist, a social worker, a behavioral health provider, a coordinator, a nurse, a chronic care assistant, community health worker. We are broadening the team because we need an all hands on deck approach to meeting where our patients are when it deal with chronic conditions as well as food insecurity. The power of the prescription, I just want to connect the idea of prescription and pharmacies together. A prescription, if you look at the origins of the word, it is a recommendation with authority. So we write prescriptions all the time, recommendations with authority, the authority of healthcare. And in our model, we are expanding the notion of a pharmacy. Pharmacies are usually well-developed places that distribute medications You go, you get your antibiotic, you get your blood pressure medicine. And what would it look like if our pharmacy was actually the food pharmacy, and the food was easily distributed, like we have in our system, or the behavioral pharmacy, where you have a delivery platform for hardwiring life habits. That's what we're trying to achieve here. So play on pharmacy, and double downing on the concept of the prescription. In terms of my work, I've been doing this now for 3 years at the county level, and then prior to that, I was doing it at the health center level. We have 5 health center systems now partnered with us in Alameda County, and it took some time to build during COVID. Done probably 46, 48 trainings, 450 staff trained, and the staff are using the services. They're making referrals to our team, about 3,500 roughly referrals and counting. In terms of our spread across the county, this doesn't mean as much to you all. We have 5 districts. We have 5 health centers: Bay Area Community Health, the whole health system, the county health system, Native American Health Center. We have a Native American Health Center, Tiburcio Vasquez, and Lifelong Medical Care. In terms of the population served, again, this may not be useful to you all, but the Bay Area is fairly expansive as a county, all the way up from El Cerrito, Berkeley, Oakland, Alameda, down to Fremont, and out to the East Bay, to Pleasanton, Dublin. The bottom line is we have a footprint. When we created this geo map, we looked at where are our drivers going and where are patients located, and it serves all the districts. And I was thinking, well, what makes sense to Kansas? So in Alameda County, we have 1.65 million people in our county. And at least when I looked at the population census data in Kansas, in your state, you have 2.91 million people as of 2022. So we're a little over 50%, 56% of the population of your state. That's what we're serving in one of our counties. And this Alameda County is fairly diverse and large county. In terms of who our health centers are serving, 83% BIPOC, BIPOC being Black, Indigenous, people of color. This is the kind of just the demographic breakdown. You'll see a very diverse mix, perhaps different in Kansas, made a different representation. When you look at our Recipe4Health clinics and who they serve, it's roughly the same, 87% BIPOC, Black, Indigenous, people of color. Language preference here, race and ethnicity differences here. In terms of the bread and butter, what we in healthcare see, 49% of our patients have 3 or more of the following diagnoses. This is the stuff that we see every day. And 29% of our diabetics, 14% have depression and prediabetes. Okay, so I'm gonna pause here because I've just gone over the 3 ingredients. Are you all tracking? Are you with me? Is this making sense post lunch? I know that can be a slump sometimes energetically. How are we all doing?
I think we're holding up. We do have a question back to ingredient number 2, I believe. And the question is the open wellness model, which essentially appears to be a group medical visit where a provider's present, is the provider present in order to bill, which helps support all the other non-billable components such as exercise, cooking, those other things? Can you talk a little bit about that?
It's a great question. I'm going to get to it at the end when it comes to sustainability and Calif and the Medicaid plans. The group visit is one of our models. We have it where we have the medical provider in there, and the provider sees the patient in individual Zoom rooms while the health coaches are working the rest of the group, and then sometimes makes appearances. So it's great for the health center on a number of fronts. And I've done this myself. I've been a group provider. In a typical half day in one of the clinics that I worked in, I was averaging 17 to 18 patients in a half day. My maximum was 23 in a half day. I don't know what your productivity is in your clinics, but this was a productivity amplifier. Not that this is about production, but I know that the CFOs and COOs, they want to make sure the CMOs that there's a nice connection between quality and production. So we were able to bill for all of this. All of that revenue came to the clinic, especially now in Calif with our whole Medicaid shift. This service of the health coaches, which has a cost, it will be covered by our health plan. The food has a cost, it is covered by a health plan. In our preliminary years to get us to this moment on September 1st, health plans that were interested in this model and these services use the group to create enough provider visits to take some of those extra surplus, if you will, to pay for some of these services. It's tough for health centers to do that, right? CFOs will fight with the CMOs, and the CEOs are like, hey, we're just going to use these dollars for these things. You know, we're not going to pay for food. We're not going to pay for health coaching. It's out of our system. I will say this is where the health plans and our Medicaid shift has been amazing for scale and moving beyond just visionary leaders or visionary CEOs who are having to align their C-suite. That is only one model of our model. We also have groups at the county level that are not at the health center that do not have a provider in them. And it's mainly just the health coaches. And then we're also now expanding into individual coaching where the health coaches talk to the individual member. Let me pause with that. I gave you a mouthful, but I'm curious if that helped to answer the question.
Yeah, we have one more question for you.
Go for it.
Hello, this is Davna Gould from Health Core Clinic. I had a question about the composition of your classes. Could you give me just kind of an average class size?
Sure.
Sits?
So I want to be careful in language here. We actually call these group medical visits or shared medical appointments because that's in the literature, and it allows it to be a billable visit versus a class, which is often health educator run, which are then not billable visits. So our composition for our group medical visits, it ranges per health center. The one that I was at, we were averaging 17 to 18, and they were a range of these patients you see on the screen. Multiple diagnoses, different conditions. One of our smaller centers ranged around 9 to 10 or 10 to 12. So this is where it depends how well structured the clinics are in wanting to, are they excited about groups? It's tough to build group medical visits, a traditional group medical visit. That's why we have this hybrid where it's open source wellness and the health coach is holding the space. So the provider is really doing a very focused section on just the medical piece, but then also having the time and space and knowing that the health coaches are there to support the patients while they're in the individual rooms on Zoom.
Okay, and then I had a follow-up with the health coaches. Do they have credentials?
We do. They have a certification. Our health coaches are certified. There's national certification now for health coaches.
Okay, thank you.
You're welcome. I'm going to keep on going. This is more for the data folks who want to see outcomes. This is not the most up-to-date, but it's the most recent iteration, at least I've been able to put forth on paper or for a presentation. Looking at the reach of our program from March 2020 when the pandemic hit to July last month, we've touched around 2,800 patients, gotten food deliveries, and then about 14% of them, 389, have gotten health coaching. And that's by design. The food has been able to get this broad appeal to everyone. And health coaching, as with many things, some patients can't commit or can't do it or the time doesn't work. But as we expand these layers, we anticipate this number going up because we want everyone to have the option. And we are making everyone have the option to have food, to have the health coaching in addition to food. In terms of total food amounts, that's 37,000 bags of food. Each bag is around 16 servings, so almost 600,000 servings of food, regeneratively grown, organic, or regenerative organic food. Kind of like your Whole Foods, if you have Whole Foods in Kansas, without the whole paycheck, right? Because this is a free service through the health plan now as a prescription. Our preliminary outcomes that I'm going to run through now, based on about 254 patient surveys enrolled in the groups in the food pharmacy lab work. There were some that were food only and some that got the group. And then we looked at a subset of diabetes and depression patients. In terms of health behaviors as a group, we looked at fruit and vegetable intake. Pre is in green, post is in blue. Same thing here with physical activity. The bottom line here is we went up about 0.9 servings a day, about 1 serving a day. And you may think that's not a big deal, but I'm going to show you the next slide where it actually shows why a serving a day is a big deal. And this is just on the behavioral piece. Physical activity during the pandemic actually went up. I don't know about you all in Kansas, but in California, most of our patients stayed indoors and the minimal physical activity, either working at home or just stuck at home. we actually were able to increase the amount of physical activity. Certainly not that where we wanted at the 150 national guidelines, but in a pandemic year, from 60 to 106, not bad. 47 minutes more of exercise in a week. I want to dive into this because people think, one serving a day, what's the big deal? This is not my study. This is an important study in the literature. It shows if you increase your veggie and fruit intake, your deaths go down. And the bottom line is you have a chart here that shows if I'm at 1 fruit and vegetable serving a day, 2, 3, 4, 5, 6, 7, 8, what is the reduction in mortality? And it turns out that an increase of 1 serving, which is where we're at, half cup of fruit and vegetables a day, decreases all-cause mortality by 5%. Just that 1 serving, if we extended that across the nation, that's 30,000 lives saved. Because of the implications, cardiovascular, all these mechanisms that we're now learning in terms of pro-inflammatory pathways, anti-inflammatory pathways, insulin resistance pathways in the body, just on the food alone. So you often hear at the national level, we say 5 a day, 5 fruit and vegetables a day. Well, that's because at 5 here, you'll see that it starts dropping off. So at 5 a day, you're getting about a 25% reduction in all-cause mortality. This is medicine. I think in med school, we don't even think about this because we want all the complex stuff with the drugs and everything. But if we go to fundamentals, if I'm dosing myself at 3 times a day, breakfast, lunch, and dinner, what I put in my body has massive impact over time in terms of my physiology and outcomes towards health. Just a few qualitative stories. Gabby's a food pharmacy group visit patient. She said, good things have happened because I also make my family, my husband, and my 2 children eat healthier. My husband sees that I'm going to do Zumba, and I tell him, hey, let's do Zumba. Come on, everyone. And we do Zumba as a family, and that's what I like. Concept here is just that you treat one patient in the family, especially the mother, and you get massive ripple effects and secondary benefits to other family members. And then just to the former point about veggies and fruit, people who have never eaten vegetables in their life are now eating vegetables. That's what our health coaches are saying. Again, it's complex in the US. We have a difficult time differentiating food from food-like substances. So many things are processed and packaged, they're not even real food, but we don't know any different, right? Especially if you're in underserved communities. Diabetes, let's look at diabetes and improvement in blood sugars. Are folks in the health coaching and food versus those that weren't in health coaching and food a similar difference? It looks small, a 0.5% reduction. These are patients for the clinicians in the room. They have an 8.6 hemoglobin A1C. This is a technical number just to show how bad is someone's diabetes. It's poorly controlled at 8.6. We're able to show a 0.5 drop. I think we'll see more, but 0.5 is clinically significant. And then this is statistically significant. So this is early data, just early slices. And our evaluation team is looking to see, does this bear out? Staff perspective on that. One of our clinicians said, Sarah, I just met with a patient with diabetes yesterday who was able to stop one of her oral medications. So we're seeing some de-prescribing, and then had been able to further reduce her insulin a little bit. I would expect she'll be able to further reduce her insulin. I'll share with you one of my stories. I saw one of the patients, 65-year-old-ish Mexican-American woman who had diabetes and had been on insulin for 15 years. Her dosage of insulin was 76 units a day. That's a lot, 76 units a day. Through our work together, we were able to get her down to 0 to 5 units of insulin a day, keep her on orals, make all of these changes, sustain it, and reduce her events of low sugar events that often led to her going to the hospital. That's just an anecdote, but it's an important one. And we as clinicians, we see this, right? We see certain things happening in our patients when they're given the opportunity. Mary is just another health coach saying she's looking at a diabetic. The symptoms that have come from diabetes have lessened for that patient. One of my patients, when she started, she was used to have full body pain and her diabetes was really out of control. Now she's gotten to a more normal range for her diabetes. She doesn't have as much physical pain. And there's really interesting data showing that uncontrolled diabetes or just high levels of sugar have joint pain effects, inflammation in joints, and orthopedic folks are talking about that. The patients with diabetes treated with the food, improvement in cholesterol, 20% reduction. This is so-called the unhealthy cholesterol, but we actually need LDL, so it gets a bad rap. But we're seeing a reduction, a 20% reduction. That's equivalent to a low dose cholesterol medicine called a statin. We're seeing a reduction in triglycerides, the fat in your blood, which is really a marker of processed foods or sugar in your diet. We're looking at food insecurity as well and seeing an important change. Here in Alameda County, where I'm sitting, 30% of our households were food insecure compared to the national average in 2020 of 14.8. So we're double. And our patients, we in the community health center serve the most vulnerable. So we're starting at a baseline of 65.7% for one cohort being food insecure. And each month, that baseline, that proportion of food insecurity drops. It'd be wonderful to bring them to zero, but just to show that we went from 65 to 40 was statistically significant and there was some power to it. Social isolation has dropped during COVID, which often increased during COVID, so we're moving in the right direction. Depression scores based on this measure called PHQ-9 for the clinicians in the room, that dropped 23%. That's basically moderately severe depressed patients becoming moderate depressed patients. So that's a categorical drop in categories of depression. Anxiety, severe anxiety, becoming mildly anxious. Again, statistically significant. Numbers are still coming out. Blood pressure, this is a different set of data. This is when I was a med director at Alameda Health System at Hayward Wellness with small numbers, but we saw something in our small numbers. Those who were in the group, when we looked at their blood pressure before and after, we saw on the average a 16-point reduction. And for the non-clinicians in the room, if you have blood pressure yourself or your family members do, if their blood pressure is in the high range and it goes up 20 more points, that's associated with twice the risk of death from a heart attack or a stroke. So we're going in the right direction. Small numbers still, and we don't know what this is going to look like, given that in COVID, many of our patients weren't coming in for blood pressure checks. So we'll see where that comes out. Illness outcomes data. This is interesting for our health plans and our CEOs of our systems. We were able to show a reduction in hospital and ER visit days from 22 days down to 5. That's a 77% reduction. This is, again, the work at Hayward when I was the medical director. Small numbers, was not statistically significant, but we're going to look at this data because there's something going on there potentially. Illness from a CDC score, this is just to tell us from a physical and mental health well-being perspective, did patients feel better? And they had. Overall, they felt better. And then how do you do all this, right? You have an evaluation team, you've had speakers speak. We started early in creating an architecture around collecting data. I partnered with colleagues at Stanford School of Medicine, University of California. These are my alma mater places, our local health network that can pull the data, and then working with the USDA on some of these metrics. I'm going to close with CalAIM and systems change. CalAIM is California Advancing Innovations in Medi-Cal. Medi-Cal is Medicaid, so you guys have Medicaid. What we've done with Recipe4Health is we've worked at the national level. I've testified to Congress on this work, met with the Secretary of Health and Human Services who toured our area and gave a presentation. And Representative Barbara Lee was at that presentation, and she wants to launch a food as medicine pilot that's national. So that's kind of going through the whole pathway. And she sits on appropriations and the USDA and the Ag Committee. And then there's September next month, there's a White House conference on hunger, nutrition, and health. So maybe you have given input on that. At the state level, we have this amazing opportunity called CalAIM, California Advancing Innovations in Medicaid. This is a 5-year window where it's a waiver. The feds have told the state, we will support you in letting the health plans opt in to pay for some of these interventions that would normally never be covered, right? Who's going to pay for the food? Who's going to pay for the health coaching? Well, that's what we're going to use CalAIM for. At the same time, I worked with Supervisor Chen. We put together 2 bills that went to the state. It got unanimous passage through the health committee from Democrats and Republicans. It didn't make it through the end because COVID hit and there were other priorities. And then in our county, we've implemented we've signed on to the Good Food Purchasing Policy, which directs our agencies to purchase food and to really think about the sourcing of the food. So another mechanism to drive change. What does CalAIM Community Supports enable? This is really for the policy people in the audience, in the Medicaid, and the plans. The state allows our health plans to opt in to provide, quote, non-traditional services like food in base interventions. And so we have two major categories. The work that I'm doing with Recipe4Health is medically supported food and nutrition, and then the work of other teams that are doing prepared meals, medically tailored meals. Our goal is to have these food-based interventions as prescriptions that are covered benefits for health plans. It's no longer opt-in. It's everyone in all health plans in the California offer this, and the health centers can and the clinicians can prescribe this. I'm going to close with 2 slides. What are the ingredients to grow Recipe4Health successfully? It requires leadership, and I say this part because I'm wondering where are you all on your journey? We had the board of supervisors at our county, so policymaker leadership. We have healthcare services, the whole healthcare department, great leadership from Colleen Chawla, who's one of my bosses now, is the boss in my section. All In was the innovation hub when I was working under the supervisor, and Larissa Estes there, our whole county. So leadership is important. So who are your equivalents in leadership? Health systems. We had 5 health systems sign on over time. Which FQHCs are going to sign on? Funders. You have the Sunflower Foundation. We had Stupski and Hellman. We brought in funding from the nation, from the USDA. We had our local health plan invest before Calif came in. They saw this early, and the CEO Scott Coffin said, "Let's do this. We want to make this happen." And now, 3 years later, we have Calif making it happen. He's ahead of the game. You need operators on the ground, the program partners, Dig Deep Farms, Open Source Wellness, the partnership with the Sheriff's Office, and then an evaluation team that I've shared before. So my last question to you all in my remaining time is, what might Recipe4Health look like in Kansas? Will it be a Kansas Recipe4Health? And then if you have questions, I leave you with my contact information, and I will turn it back to Elizabeth. If you all want to use some time, I do have a 3-minute video that gives you a visual and stories of Dig Deep Farms, and then a 45-second piece on open source wellness. But I'll hold, and I'll pass this back to
I am seeing
the team.
nodding heads. People would love to see the video.
Okay, so you have time. This is 3 minutes. This is Troy. Troy is amazing. He's a farm manager for Dig Deep Farms, and tell me the audio should be connected. So let me know if you can hear it. Yes, no?
We can hear.
Everybody has trials and tribulations in life. You can always relate it back to something like this. From the surface, it just pokes out, but when pulling weeds, you want to get to the root. It helps you not have to constantly do them, which allows the things you want to grow properly. When you're incarcerated, you're in a cell, and all you want to do is be outside. August 8th, when I found out about this opportunity, I definitely wanted to seize the moment and ease back into society in a productive way, maybe correct some bad habits, learn some good ones.
Break the hole, press it down, get it down deep enough to kind of blanch the stems of the allium plant leak, and then press down to make sure all the air pockets are compressed. Here at DD Farms, we teach urban farming in a sustainable way that will be healthy to the community. To help them, with people that come into it, come back and contribute to the community, and also thrive and be resilient and grow like these gardens do.
Being an intern at Dig Deep, it was a blessing. It was something to get me back on my feet, to get my life back on track. After I finished the internship, they gave me the opportunity of becoming employed with Dig Deep. The farmers harvest, and then I transport the vegetables here.
dancing the other day. I haven't danced in years. I really believe that it's because I eat here all the time.
This is all data.
My favorite part is knowing that I made a difference in somebody else's life, just as well as the reentry program made a difference in my life. So it's almost like just paying it forward.
The Dig Deep Foreign internship, I've seen it help folks in their retreat paths. A lot of times they have like a lot going on, pressures. Just stopping, touching soil, touching plants, eating safe plants, give them education and a sense of focus to that. And just land reconnection.
Coming here and doing this, it humbles you to see something sprout, and over weeks it grows, makes you think about your life and what footprint do you want to leave. I'd rather leave a footprint in the dirt at a farm than a footprint that's used as evidence.
So that's Dig Deep Farms. And then if you wanted to see a 45-second video, but I'll pause, you can see what open source looks like virtually. So again, check in with the audience. You've been with me for an hour. I don't want to
We can
tire
do
you
the
guys out.
45 seconds.
Okay, here you go.
Open source wellness delivers community as medicine.
Individuals and families are struggling now more than ever with social isolation,
Depression, diabetes, hypertension, and more.
At Open Source Wellness, we partner with health insurers, healthcare providers, low-income housing, and employers to create virtual communities of belonging, vitality, and resilience.
We offer small group coaching and live support for the daily practices that drive health and well-being, like physical activity, healthy meals, stress reduction, and social connection. Visit opensourcewellness.org to learn more about partnering or participating.
All right.
Wow.
Back to you all.
I think we're all sitting here a little bit stunned, like we don't know what to take in first, right? There's so much. Do we have any last questions or comments? All I will say is that personally in the Deep Roots video, his quote about a footprint in the earth gave me chills. That was beautiful. So you've given us so much of your time and expertise today. We are very grateful. Thank you so much. I have a feeling you're going to be Googled even more now after this. So just being forewarned. Would the room join me in thanking Dr. Chen for his time today?
Thank you so much. And if you do want to do Q&A, if it makes sense, I can hang out a little longer. I was able to extend my time, but I'm also fine if you are all moving on to your next section. So just want to let you all know that.
Giving the room one last look. Okay, we're taking the mic over, and I'll let you know this is Celia, who represents one of the MCOs in our state.
Yes, good afternoon. Thank you for sharing all of this with us. This is pretty cool. So I'm curious to your September 1st launch. And so then from what I understood, you'll be sharing something with your legislators, correct?
September 1st launch is happening next week for Calif. It's already been passed. This is the federal waiver. And so the whole state of, the whole county is going to do it September 1st. This actually started January 1st for the whole state. So we have 5 years for all of this to happen. And our county needs a little extra time. So we started it September 1st.
Okay, perfect. So I guess from like the policy side of things and getting your policymakers involved in this, were there any arguments that you had to maybe work extra on to kind of get them on board with this?
Yes, I mean, in general, we had a fairly open and supportive stance. I think the question in the beginning is who should pay for it? Is this a healthcare should healthcare be involved in this, right? It's more of the traditional siloed thinking. And when the Department of Healthcare Services in California is looking at their budget, they're thinking, wow, we already spend so much on healthcare. Now you want us to pay for food? Like, how can we do that? And we had to show them the evidence and show them that if you spend $400, $500 on food for a month for a family, that is far less expensive than a $15,000 admission for someone who's diabetic, who gets low blood sugar, right? So there's that initial getting over the hump. How we addressed that was having our policymakers and we created bills to put the attention on the administrative bodies like Department of Healthcare Services, say the legislature is interested in this. They want to push and ask for food as medicine interventions. That always puts the departments, the administrators on alert because they look to the policymakers for leadership. The other piece is finding champions, policymaker champions. We had Assembly Member Rob Bonta sponsor the bill. He did it twice. There are other Assembly members that take this on. And so it's important to find your champions.
Thank you.
You're welcome.
Any other questions? Okay. Well, thank you again so much for your time. We greatly enjoyed this. This is Elizabeth talking. I know you can't see me. I'll be in touch via email. So
Great.
thank you
Thank
very
you all.
much.
Congratulations to you all for being here. Take care.
Great.